the infrastructure of which we can use to think about the talks that are here, how we care for our patients and ourselves if we are the patients. But also, it cannot be minimized how important the work that has been done in melanoma in the first line has contributed to other solid tumor care, all of the checkpoints, the targeted agents, the BRAF agents, but also how it has translated into the care of other types of melanoma, including ocular melanoma. Here at the Angeles Clinic and Research Institute, the ocular melanoma guru is Dr. Inderjit Mehmi, who's been here for half a decade. It seems like just yesterday. So I will hand off to the young Dr. Mehmi.
Thank you very much, Dr. Hamid. Yes, it's been about 5 years since I started, and it's my third or fourth presentation. Been really good experience so far. So today I'm going to take some time and walk everybody through current care of ocular melanoma and what are some of the upcoming therapeutic options for our patients. So this is just my roadmap for this presentation: background, prognosis, staging, and what's missing from there is the talk on adjuvant and neoadjuvant approach, and then subsequently metastatic disease management. So these are some of the spaces where ocular melanoma or uveal melanoma develop. And as you know, that this is not the most common malignancy, but it is one of the most common malignancy of the eye in adult population. About 2,000 cases in the U.S. each year and about 8,000 cases globally. As we know, the risk factors of the sun exposure for cutaneous melanoma, that's not the case for uveal melanoma. Those risks are still being looked at. But other risk factors that we know are the nevus and the choroidal space, melanocytosis, any family history of uveal melanoma. Some of the other germline mutations can also. So once a patient is diagnosed with primary ocular melanoma, it's important to look at their staging, their primary melanoma staging, because that informs us what are their future risk of developing metastatic disease. We know that about 50% of the patients will go on to develop metastatic disease, and it can be or has been in the past quite challenging to manage these patients. So some of the prognostic or predictive prognostic marker that we use are the tumor size itself, basal diameter and height. And additionally, we've been using gene expression profiling in uveal melanoma. That's very well studied, where the tumors are actually sequenced and split into either class 1 or class 2. And based on that, we know that their long-term outcomes can be predicted fairly with good confidence. As you can see that, if you're a class 1 subgroup, you're likely to do fairly well. And they tend to be very different in terms of their recurrence risks and how far they recur. They tend to recur later in time rather than early on, where class 2 are the sort of early recurrence patients. And then some of the additional information that we've seen is the PRAME antigen, which we'll talk about a little bit later as a target, but it's also a prognostic marker. Individuals who have ocular melanoma that are not only class 1 or class 2, were also differentiated based on their PRAME presence. Having PRAME marker on the uveal melanoma will actually portends a poor prognosis and decrease overall survival. So going back, looking at, is tumor size good enough as a prognostic marker? Well, not exactly the case. We still tend to use that, but most often the gene expression profiling and PRAME and monosomy 3 are some of these markers that we will use to define a uveal melanoma being a high risk or not. And why is that important? Because that allows us to at least look at these patients and trying to offer them therapeutic options, either in standard of care or in clinical trial setting, to reduce their risk of recurrences in the future. In the past, this task has been very challenging. As you know, the uveal melanoma is not the most common disease. So doing large trials that are required for adjuvant therapies aren't all that, easily done. But that is changing because, the road's been mapped for us with number of clinical trials, with number of different target therapies or immune therapies or intralesional therapies to see if we reduce the risk of recurrences. Most of these trials have led to sort of mixed results. Occasionally, I'll see a patients who received sunitinib, a multi-tyrosine kinase inhibitor, in adjuvant setting because it's known to improve overall survival in patients who are under 60 years of age. But the rest of them are sort of a bit of a mixed bag. Until last year at ASCO, when one of our colleagues, Dr. Apiswan from, I believe he's at Georgetown, he presented the data on ipilimumab and nivolumab that was used in treating patients who had high-risk uveal melanoma. And what high-risk meant was their class 2 or their tumor's basal diameter was greater than or equal to 12 millimeter. And these patients were treated with nivolumab 240 milligrams every 2 weeks and ipilimumab 1 milligram per kilogram every 6 weeks, up to 48 weeks, with a primary endpoint of 3-year distant metastatic free survival, and also had a couple of secondary endpoints. And they compared it to a standardized control group from the cooperative ocular oncology group. And when they did this sort of synthetic arm comparison, the individuals who that received ipilimumab and nivolumab actually showed improvement in their DMFS outcomes. It was 70% versus 43% with the propensity score matching method. And then median DMFS wasn't reached in these patients. So as you can see, that this is a reasonable option for some of these patients, but this is a small study. We know that ipilimumab and nivolumab could be quite toxic for some of these individuals. So we do need bigger numbers to sort of make this as a standard care for our patients. So since the roadmap's already there, now we're looking at some of the other therapeutic options that could play a part in adjuvant sort of therapeutic space. And we're going to talk a little bit later about tebentafusp or Kimmtrak, which is FDA-approved therapy for HLA-A0201 positive patients with metastatic uveal melanoma who haven't seen any treatment before. It's shown overall survival benefit, meaning it's already proven to work in advanced stage. Can we bring that therapy in early setting, in adjuvant setting, to see if we can prevent some of these recurrences? So this ADAM trial, which will be open at our site soon, and is actually planning to be open at multiple sites in the United States, looking at high-risk patients who had TNM stage 3 or gene expression profiling class 2 or have monosomy 3 in their uveal melanoma. They have to be HLA-A0201 positive, and the treatment is with tebentafusp up to 6 months, and then endpoints of primary at relapse-free survival and secondary endpoints being overall survival, toxicity of the therapy, and quality of life. The flip side of that is, what if you don't have HLA-A0201 allele? Then what is your adjuvant option? We can't leave you alone in a sense, because if you have high-risk melanoma, for example, GAP class 2, what are some of your options? Well, there's been sort of preclinical work looking at BAP1 mutation and what its role is in metastases driving genes. And we know that they're upregulated. And crizanlizumab is a drug which inhibits histone deacetylase 4 enzyme, and it sort of decreases these metastatic driving genes and hope to reduce the risk of recurrences. So that's the preclinical work. So based on that, University of Miami team has put forward this trial that will be opening up. And it's looking at crizanlizumab treatment, 12 milligrams via capsule taken orally 3 times per week for a 21-day cycle and total of 17 cycles. So roughly about a year of treatment. And with the primary endpoint, again, of distant metastatic free survival, with the secondary endpoint being progression-free survival, overall survival, first site of recurrences, and adverse events. So we're actually very excited to look at these options, multiple options in the adjuvant setting with a really good scientific background or already clinically established benefit. A few years ago, we had only one therapeutic option in metastatic setting, and now we have more than few, and we're talking adjuvant therapy in uveal melanoma. And on top of that, we're talking about neoadjuvant therapies in uveal melanoma. What is neoadjuvant therapy? Before the primary eye tumor is treated by radiation, the typical plaque therapy, or for some of the individuals that need their eye enucleated, can we give them treatment to reduce the amount of radiation or the plaque size, or can we sort of reduce their risk of enucleation? And that's the neoadjuvant approach, and it's proven to be amazing in cutaneous melanoma. And can we apply that sort of principle in uveal melanoma as well? There's been a signal that's been seen using darovasertib, the IDE 196 drug from IDEA, that's already in first-line phase 3 study in metastatic uveal melanoma, and seeing if that could be applied in neoadjuvant setting before the metastatic disease is developed, and to reduce the size of the tumor, reduce the chances of enucleation. So they've seen some responses, median reduction of about 47% in the tumor. Most of the patients benefited. So based on that, the neoadjuvant study is ongoing, and hopefully we have more data to report on. Additionally, the neoadjuvant study by Aurora Bioscience, they're looking at a virus-like particle packaged that's injected close to the tumor in the eye, and that leads to destruction of the cell membrane of the tumor and releases these signals that the immune system can pick up and hopefully learn to control the uveal melanoma cells whenever they move somewhere else or recur. So again, this trial is ongoing, and hopefully we'll have some data to present on it in the future. So as we already talked about, that a lot of the patient, or 50% of the patient, will develop metastatic disease, if they are high risk. And many times this metastatic disease tends to be in the liver. Up to about 80% of the patients will have disease in the liver. So are there mechanisms to treat the liver only rather than treating the whole person, which usually leads to increased side effects? Well, yes. There are a number of liver-directed therapies that are available, and a lot of them shown limited benefit, not overall survival advantage, but some progression-free survival benefit. And there are a number of different ways: immunoembolization, chemoembolizations, radioembolization, perfusion of the liver itself with chemotherapy. And one such thing or therapeutic option is percutaneous hepatic perfusion, PHP, which actually is already FDA approved over the last couple of years and is in application. And here we use to isolate the liver supply of the blood supply of the liver and infuse it with melphalan high dose, and that's shown to decrease the liver burden. And most of the time, the toxicity tends to be limited, and it's mostly the cell counts that decrease in nature. Some nausea, vomiting, increase in liver enzymes also been seen, but this is actually FDA-approved therapy that is available at selected centers. Okay. We talked about, Dr. Moyer spent a good bit of time on targeted therapy. Are there opportunities for targeted therapy in uveal melanoma? Well, we know that lots of the uveal melanoma have GNAQ, GNA11 mutations that seem to drive the cancer, and their downstream signal, can we interrupt that? And that's the basis of darovasertib with the crizotinib to see if that could be sort of applicable interruption of the signal transduction to improve patient outcomes. In the past, other protein pathways been looked at, with sorafenib, sunitinib, trametinib, and most of them have had very limited overall responses, not durable, toxicity issues, so they haven't been really widely used in this. So this is the IDEA 196 compound, or also known as darovasertib, that showed benefit in an early phase study with a 50% overall response rate in the first line metastatic uveal melanoma, 30% overall response rate in patients who have received prior therapy. So based on this data, the phase 3 study is ongoing, and we'll have some data available to report in the future. We also know that immune system is quite important in cancer control, especially in melanoma. However, uveal melanoma is what's thought to be a cold tumor. There are not a lot of immune cells present within the tumor, but there is a small group of patients who still benefit from immunotherapy. That's been demonstrated in two separate trials, one led by MD Anderson team, another one in Spain. Both of these studies used ipilimumab, nivolumab in metastatic uveal melanoma that hadn't received prior therapies, and showed about 18% response rate. Some of these responses are quite durable. And we didn't see any newer toxicity in uveal melanoma because of ipi-nivo. So it's an option for some of our patients. So one of the most interesting sort of upcoming studies, I think, is for patients who are HLA-A0201 negative or potentially, not candidate for whatever reason for IDEA study. I think CHOPIN trial looks very promising, even though it's only a 7-patient data that looked at combination of ipilimumab and nivolumab and liver perfusion with chemotherapy. And this is shown about 80% overall response rate with 1 complete response, 5 partials, and 1 stable disease. I think it's a story that's developing, and we look for more data in this and expand on this experience. Next, to talk in space of metastatic uveal melanoma is, again, continuing with immune sort of control of cancer. And we know that T-cell, cytotoxic T-cell are very important, but we need to get them to the right place. So to do that, it's these MTAG class molecules that bring in T-cells from the periphery into the tumor to control metastatic uveal melanoma. And this is established by demonstration of overall survival benefit with tebentafusp in metastatic uveal melanoma, published in New England Journal of Medicine in 2021. And it showed that, in HLA-A0201 restricted patients, when tebentafusp was given and compared to either pembro or ipi or chemotherapy, the overall survival was increased for patients treated with tebentafusp. And now we have 3-year data, follow-up data, and that still shows ongoing benefit. The median overall survival for tebentafusp was 21.7 months, and for the control group, it's 16 months. So obviously showing benefit with the risk of death at with it 0.5%, I mean 50% of reduction in risk of death. Most of the adverse events that tend to happen with Kimmtrak or tebentafusp, they are focused in the first 3 doses, and that's mostly cytokine release syndrome, fever, chills, and most of these low blood pressures. Most of these are low grade, and they tend to improve typically with hydration, acetaminophen, and things like that. In a small, very tiny fraction of patients, they may need steroids or other ways to improve their blood pressures. And skin rash is quite common in these patients, but typically improves with topical steroids and rarely oral steroids as well. other ways to bring these T cells. As we talked before, that PRAME is an antigen quite widely expressed on uveal melanoma cells, in addition to some of the other tumors as well. And Dr. Hamid's presented this data at ESMO a couple of years back, showing that this is an approach that potentially is meaningful for uveal melanoma patients. And there were a handful of uveal melanoma patients, but they had ongoing benefit, durable benefit. So we'll look to develop this story further in the future. Dr. Moyers talked to you guys about RP1, the modified virus injection into metastatic site, and showing benefit in the uninjected lesions as well. So RP2 is the counterpart here to RP1 in combination with nivolumab to show you benefit in a metastatic uveal melanoma. This trial is ongoing, but the phase 1 study showed that there is a potential for benefit when you're looking at RP2 in uveal melanoma. So these are the 17 patients that were treated with RP2 and nivolumab together in a single arm study. Objective response of 29.4% and a disease control rate of 58.8%. Safety, most of the toxicity are in the injected lesions or injection site reactions. And significant number of these patients underwent intrahepatic injections without any significant issues. These are some of the characteristics of these patients that were treated. So there's an ongoing trial. Dr. Moyers also talked to you about the TIL. There is signal of TIL in metastatic uveal melanoma, but number of patients treated is small. So this is not a complete story, but we look to see its development. Can happily ask any question, answer any.